Hello and welcome back to Season 2 of Fertility Talks, the Therapy Fertility podcast. I'm your host, Renee Von Medding, and I'm so excited to be back hosting our second season. Each week, I'll be sitting down with a different guest and chatting all things fertility. As always, our hope is that through this series, through honest conversation and information, we can strip away some of the stigma that sometimes goes hand in hand with infertility and fertility treatment in Ireland. Today, I'm delighted to have in studio with us Dr. Sarah Murphy, who is a Dublin-based doctor working in obstetrics and gynecology. She has a special interest in women's health, including exercise and nutrition, and also has an amazing Instagram account where she shares lots of valuable information on female well-being and fertility. So welcome to the podcast, Sarah.
Thanks, Renee. Thank you so much for having me on.
I'm so excited to meet you in person. I love your Instagram account. I think it's amazing, all of the stuff that you share. It's so honest and relatable, easy to understand, and I know so many people get so much from it.
Thank you. It's so nice to hear that, because I suppose that's the aim for women to take something from it. So to hear that might be achieved is great.
And when actually did you start the Instagram account?
I actually started it years ago when I was in college, and actually focused more on my fitness.
Yeah.
And then I had to take a step back from that, and I sort of asked myself, what's the aim here? I didn't think it was achieving anything.
Yeah.
And then as I started to work in the job, I can't really pinpoint the time, but it transitioned into actually an information account for others.
Yeah.
And now I feel like it's achieving something and isn't just a useless.
Yeah, you're not just doing it for the sake of it. You're not just creating content that's doing nothing. You're actually,
that just wouldn't mean anything to me, and
Yeah.
I'd find that frustrating.
Yeah.
So now it's, I suppose, to try and give something to others.
Yeah, no, it's really nice when you can actually see that people are getting something out of it.
Exactly.
Yeah.
And I suppose even if, you'd say if 1 in 10 women take something from it, then it's worth it.
Yeah. Okay. So tell me a bit about yourself.
Sure.
Where you're from.
So I'm from Ireland. I'm from Athlone, so the Midlands. Went to college here, did medicine in UCD, and then specialised in obstetrics and gynecology, and now work in the Coombe Hospital in Dublin.
And did you always know that was, well, first of all, did you always know you wanted to be a doctor?
No,
first of all.
No, and do you know the way you meet people and they have this really profound story of why they wanted to do medicine, whether they suffered from illness or someone they loved.
Yeah. They wanted to fix people. You don't have that.
I don't have that. I had that. I loved working with people, and I loved science, and medicine put those two together. I did it in college. I loved it. And it went from there. In terms of why I wanted to do obstetrics and gynae, when we're in college, we do rotations in every specialty.
Yeah.
And we had a rotation in obstetrics and gynecology, and I had never met doctors before who were such advocates for their patients. So it wasn't just about the medicine. It was, you'd hear the consultants talk and they'd be like, but you really have to think about how she's feeling. And they were advocates. And then, so that really made me love it. And then it's a really interesting specialty for us because it marries so many different aspects. So you've pure medicine, we'll say, because women have their own medical problems. You get to do scanning, you get to do surgeries, you get to see lovely babies. So it's a really broad and dynamic specialty. So it's really enjoyable.
And where did you do your rotation?
And I first started, I did a few weeks in Holles Street and a few weeks in the Coombe. So they were busy units, so you got a nice exposure to the specialty.
And now you're back at the Coombe.
Yeah.
So what do you actually do on a daily basis? Like, what would a day look like for you?
Yeah, so I suppose that's the other thing I love. Every week is different. So we'll say on Monday I'm in the operating theatre, so that's doing things like cesarean sections, D&Cs, you might do laparoscopies, you'd be assisting consultants with hysterectomies and things like that. On a Tuesday, I'm in the diabetic clinic, so that is where women
I know all about that. I'm a type 1 diabetic and I went to the Coombe.
Yes. Yeah.
So I didn't see you there. How long have you been there?
I've only been there since July.
Okay, yeah. No, my last time there would have been in 2018.
Yeah, with Prof Daly.
Yes. Love him.
Yes.
Yeah.
He's gone now.
Oh, is he?
Yeah,
he was great.
Yeah, so
but that's a busy clinic.
Busy clinic, lots going on. So it's where we see women with type 1, type 2, and also gestational diabetes who are on medication. And then on Tuesday afternoon, might be in theatre again. At some stage you do a call shift, so that's where you work from, we do 5 p.m. till 9 a.m. And then that has everything in it. Thursdays you might be on the labour ward, and then Fridays I do the preterm birth clinic, so it's women who would have risk factors for delivering their baby early, and we actually do scans to measure the length of their cervix. And that's just a typical week, and this can change based on staffing levels. So,
and would you be at many births aside from doing C-sections?
Yeah, so the days you're on call and the days you're on the labour ward, you know, it depends on the activity levels, but you might be at births. Typically, we don't attend the lovely...
Unless you need to be there.
Exactly.
Yeah.
So, you know, if I love to watch, if it's okay with the mum, we call them spontaneous deliveries, so it's where no one else is involved.
Yeah.
But if it's busy, the only births I'd be at is if mum needs
if there's a problem,
or if there's a problem.
Yeah. It sounds amazing.
It
and
is.
So exciting, and it's, as you say, it's probably just lovely to marry all of your interests, but also get to see the more human side of things and not just the medicine.
Yeah, exactly.
Yeah,
like it's just so varied, and every day is different, and you're meeting so many different people from different backgrounds. Like, it's impossible to get bored. So that's what I love about it.
Yeah, amazing. Okay, so let's go back to basics and talk about fertility. So, you know, fertility and infertility as words and, you know, terms get bandied around a lot, but what actually is fertility? What does the word mean?
I suppose in the most simplest of terms, fertility is your ability to conceive a baby, and I think we assume it until it's not there, if that makes sense. So I think, you know, and especially we all grow up talking so much about, you know, avoiding teenage pregnancy,
not
and
getting pregnant,
and it isn't then until you sit back and you think, oh, this is actually now something I need to think about. So I suppose it's the absence of infertility.
Okay. So then on the flip side, infertility is
when, for whatever reason, whether it be, you know, a factor to do with the woman, or if you're in a heterosexual relationship, a factor to do with the man, for some reason you're not able to conceive a baby. And we can split it into primary or secondary infertility, or we can split it into different factors. So
let's talk about primary and secondary, because a lot of people like really don't know that those two exist. People just think infertility is infertility, but that's not the case.
Yeah. So primary infertility would be where you've never had a baby. So for whatever reason you've never been able to conceive. So it's in the first instance. Secondary infertility is where you have had a baby and now you're not able, or you're struggling to conceive again. And that I think sometimes people think secondary infertility is fine because at least you have a baby at home, but it's incredibly difficult. And it comes with, I think, a lot of confusion and frustration. Well, I did it before, why can't I do it now? So I think the two of them need to be respected in the same amount, and I find sometimes secondary fertility isn't.
Yeah, and would secondary infertility be as common as primary?
Not as common, but it is incredibly common. I think it's more common than people think about.
Yeah, no, it's often just that kind of thought of like, sure, it'll happen, just...
Yeah, it happened once.
Yeah, it happened once, you just have to wait, you just have to relax, and that's just not the case. So in terms of the causes of infertility, are there loads and loads of causes of infertility? Is it hereditary?
There's loads of causes. We think that there may be a hereditary aspect, but as with so much in medicine, we don't have nice, clear data on this. Often we'll split it up into different factors. So it might be something to do with the ovaries or where your eggs are coming from. So, you know, is it a drive from the brain that you're not producing the hormones that are triggering your ovaries to release an egg? You might see this in something like PCOS, where we call them anovulatory cycles, so you're not producing an egg each cycle.
So would you still have a cycle in that instance?
You can, and not always. So you'll find women with PCOS may say that their periods are really spaced out, and that can often be a sign that they're not ovulating. It can be a tubal factor, so the egg has to move along a tube. The tube might be blocked, there might be kind of fluid in it, it might be sticky with things called adhesions that might be blocking it. It may be a case that there's a problem with the womb itself. There can sometimes be scar tissue or we call them adhesions. It's sort of like sticky scar tissue, we'll say. It might be a problem with, if you're in a heterosexual relationship, the sperm aren't traveling through the tubes that would bring them to ejaculate, that they don't have great motility. You know, there's loads of different aspects. And then we'd also see that there might be some conditions that, you know, cause issues with fertility. You know, things like cystic fibrosis with a man would cause issues. So there's a huge spectrum.
And in terms of like when we're talking about male fertility and female infertility, you know, is it, you know, there's often this, you know, presumption that if a heterosexual couple aren't able to conceive, that it's it must be the eggs, it must be the woman. That's not the case.
No, and if we actually split it into usually we call them female and male factors. So 1/3 is usually to do with the female factor, so to do with the woman. 1/3 to do with the man if it is a heterosexual relationship, and 1/3 unexplained. So actually, not that I never like to get into it, it's anybody's fault, but it's usually spread out equally, but it's not a fault.
Yeah. So in terms of, like, you know, we kind of touched on PCOS. Two of the like really big conditions that we're seeing coming through therapy fertility obviously is PCOS and endometriosis in terms of female factor infertility. Let's talk a bit about endometriosis. And I know sometimes there's a bit of confusion over which is which, and there's a bit of crossover, but actually they're completely separate conditions. So let's talk a bit about endometriosis, and maybe you could just explain what it is, what the symptoms are, and what the, I suppose, impacts on ability to conceive could be.
Sure. So with endometriosis, so in your womb you have a lining called the endometrium, and that's the part that, you know, builds up every month and sheds and gives you your period. In endometriosis, tissue like that is found outside of the womb. So it might be on your bowel, on your bladder, on your ovaries, or around the pelvis. And it's where it's not meant to be. So each month it responds to those hormones that, you know, give you your period, and it can become inflamed, it can lead to scar tissue. And then in terms of the symptoms because of this, you know, pain is the biggest one. I think anyone who knows anything about endometriosis has an association in their head of painful periods, which is absolutely correct. But there's loads of other ones. So it would be pain during sexual intercourse, typically on deep penetration, pain moving your bowels, pain going to the toilet to pass urine. You can have blood in your urine, blood in your stools. And then there's, I suppose, this more psychological aspects of it as well. So women typically feel wrecked, so they'll complain of fatigue, low mood and depression. So there's a huge spectrum of symptoms we see with it.
And usually at what point do those symptoms start presenting? Like as soon as a young girl gets her first period? Would it be as soon as that, or would it be later on into the teens or 20s?
It depends on the woman. So you will find often when a woman's diagnosed with endometriosis, and it can be well into their 20s, unfortunately, you'll often go back and they'll say, yeah, I had to skip school because my periods were so painful since I was 13. So you'll usually link back to that quite early. I suppose the sexual intercourse typically comes later.
Sure.
I suppose bowel and urinary issues, they'll differ depending on where your endometriosis is. So you mightn't always pinpoint those. And I think you'll find the tiredness or the low mood comes that little bit later.
And I think just as women, we're kind of conditioned to put up with a lot.
Yeah.
And, you know, I'm sure a lot of times people don't actually go to a GP or they have gone to a GP and, you know, and it just hasn't been correctly diagnosed.
And that's the thing, I suppose, as well, because pain is a subjective thing. So, you know, which makes it easy to dismiss. Because as someone might tell you, my periods are excruciating. And often I think you'll find people say, no, they mustn't be, like, you know,
take a paracetamol.
Get on with it.
Yeah.
But I think it's high time that we start listening to women and believing their symptoms for what they're telling us.
Yeah.
Because while it can be subjective, if a woman is telling you that she's not going to work or not going to school because she's in so much pain, that's, regardless if she's not in that much pain, that's significant. Does that make sense?
Yeah, to impact on your day-to-day life. Yeah, for sure.
That's significant.
And say if it's not diagnosed early enough and different treatments are not started and preventative measures, whatever they might be, what is the long-term impact of that? So if someone is suffering with endo for a long time, what does that start to look like for a person?
So obviously there's the impact on their quality of life, and how they've been able to cope. But then we get into the fertility aspect of it. So I was saying, you know, the tissue gets inflamed and then it becomes scar tissue over time. And we see again these things called adhesions. And this is where, because the scar tissue, if you think of scar tissue almost as it can be sticky, I suppose is a nice way to explain it. Everything in your pelvis is usually mobile, so your bowel's able to move and your fallopian tubes and ovaries are all able to move and coexist. And when they become sticky and stick together, that movement is stopped. In really bad endo, if you go in to actually look, you'll see the bowel is stuck to the womb and it's stuck to the bladder. And so one, that's causing severe pain, but two, it really affects fertility. So we need, you know, the fallopian tubes to be able to be mobile, to collect the egg. They need to be, we say patent, so they need to be open for the tube to move. And when we see these scar tissues or adhesions, that movement or that mobility is lost. And it really impacts on fertility. And
so how could that be prevented? Say if someone is diagnosed early, like, is there a way to prevent that happening so that a person could conceive spontaneously without needing assistance? Or like how is that prevented?
So I do think that women find this line that I'm about to say quite frustrating, but the first line treatment for endometriosis is hormonal treatment. The reason for that is the hormones are the thing that is affecting the endometriotic tissue. So if you stop that drive, you stop the tissue becoming inflamed and scarred. So we try to blunt that.
So what type of hormone would you be talking?
So we talk a lot about the Mirena coil. So that's, if women don't know, it's a coil that's put into the womb and it releases progesterone. It basically tells, if we say negative feedback, so it stops your own body producing hormones, so it stops the drive on the tissue. You can also look at the contraceptive pill as well.
So that would be like the progesterone only pill?
Yeah, you can go on the combined one either.
Okay.
So either of them would work.
So is it really the production of estrogen that like triggers off that tissue?
Exactly.
Okay.
But we find because progesterone will still send back a negative feedback loop, so it'll work, but the disease is driven by estrogen.
And why do people find that frustrating?
I think because it's not a cure, it's a treatment. And I think a lot of women will say you're just masking the disease, you're not dealing with it. And I think that can be really frustrating. And I think some women like to avoid synthetic hormones for whatever reason.
Sure.
The next thing we talk about then would be surgery. It's not very common in Ireland. So when we talk about surgery for endometriosis, there would be one type of surgery where you'd go in and you might cut the bits that are sticky, and you might burn them to stop them becoming inflamed. We know that that's not the best type of surgery. So
and what's that called?
Ablation.
Ablation,
yeah.
Okay.
The best type of surgery is excision. So that's actually where you cut out the parts of the endometriotic tissue so they can't reactivate again. It's slowly coming into Ireland. So for all of these skills, you know, people need to be trained in them to start doing them, to start training us. And that takes time. I know that's frustrating, but it does. But we now are starting to see new consultants who've trained abroad in places like Australia who are doing it.
And would that happen, say, through the maternity hospitals?
Yeah.
Would people be coming into the Coombe to have these
exactly
surgeries?
So there's two consultants, I think, at the moment in the Coombe who do this excision surgery. It's done a lot in the UK. The UK are typically a little bit ahead of us, but it is starting to come across to Ireland now.
So I suppose if someone has endo and it's at the stage where things, you know, for want of a better word, have kind of stiffened and seized up and there's no movement in the fallopian tubes, is the only option really fertility treatment, or how do these people get pregnant?
Yeah, so it can be really difficult. If you go for the keyhole surgery or the laparoscopy, sometimes if you cut the adhesions, you'll get a little bit of motility. Sometimes if one tube looks particularly, you know, closed off, you might talk about removing it so that it's just the good tube that's left. But in stages, we put endometriosis into 4 stages. When you're coming into stage 4 where the disease is particularly bad, it is often where you'll start talking about fertility treatments because you've lost the ability for the egg to move down into the womb to become a little baby. So it is often that you'll start talking about things like IVF.
Okay. Okay, so then in terms of PCOS, what is PCOS?
So PCOS is a syndrome. So it is where you have an imbalance of hormones. It's not always that you have lots of cysts on your ovaries, which I think people think because of the name, obviously. You can have cysts on the ovaries, but it's typically driven by an imbalance in hormones. So it's where women have an overdrive of the male hormone and less, I suppose, of the female hormones. This has effects on your periods, so they can be all over the place. So women might say, you know, my periods are every 60 days. And it typically means they're not ovulating.
So in terms of conceiving, that's obviously a problem, because if you're not ovulating, you can't conceive.
Exactly. So if everything's perfect, you ovulate 12 times a year. So in theory, you've only 12 times a year where you can conceive. In PCOS, you might only ovulate 1 or 2. Exactly.
Yeah,
so that's 1 or 2 times per year where you can get pregnant.
And then also, if you don't know when that is, you can't really time it.
That's the thing. Like these women, you know, they don't know, you know, one cycle might be 40 days, the next might be 60, the next might be 90. So you can't even, you know, these apps, you know, when people say, oh, follow your cervical mucus, use these apps, it's lost.
It's useless, yeah. And in terms of being able to conceive naturally, is that the main reason why it might be more difficult for someone with PCOS to conceive, purely because you don't know when you're ovulating?
Yeah, that would be the biggest reason. There is probably a theory when women have PCOS, there's also insulin resistance. We think that has a role in conception as well. And, you know, you might find that other women who don't have PCOS are, there's discussions about whether or not they're insulin resistant.
That's so interesting. I wonder why that would have an impact on...
I don't know if, you know, with loads of things in medicine, we always try to see, is there a survival benefit of it? I wonder, is it that a high, you know, if you're insulin resistant, you have a higher sugar, is that not an ideal
scenario
environment
for a pregnancy? Like, and I suppose that makes sense, because, you know, I know from being pregnant and my own, like, having to manage my insulin, you know, you become even more insulin resistant when you're pregnant anyways. And it's all over the place because it's all affected by hormones. So
it's hard to know exactly why. But I'd say that certainly plays a role as well for these women.
And what are the symptoms of PCOS? I think a lot of people would usually associate that with maybe additional hair growth. What are the other kind of symptoms? Is pain a big symptom as well?
Can be. It's less common. So usually it'll be kind of bloating and discomfort. The irregular periods, they could be heavier. And then women will say they kind of have hair growth where a woman typically isn't supposed to. So it might be on your face, on your belly, really thick hair on your arms and legs. Women might also say that they have acne. You know, they went for years without any issues and now they have acne on their face, on their back. And then as well, you'll see kind of just tiredness as well, and kind of mood disturbances with it as well. And
what are the treatments for PCOS? Or is there a treatment? Is there a cure? Or is it just something that people have to live with and manage?
With PCOS, which I think people like the idea of non-hormonal treatments. So there's diet and exercise has been proven to be beneficial. Sometimes women with PCOS may be overweight or have a BMI that's slightly higher than normal. And we find actually if a woman is to lose weight, which I know is easier said than done, some of the symptoms start to abate, which is great. In terms of trying to regulate your cycle, we do talk about starting the oral contraceptive pill to try and even get a withdrawal bleed, you know, in that week where you come off it. In terms of fertility, we can, you know, there's some steps we talk about before we move on to, I suppose, more interventional treatments. So we can talk about getting your body to ovulate. There's tablets we can prescribe for that. And also we talk about prescribing metformin. So that's a tablet that women who've type 2 diabetes might be on. And we find that it helps in cases of PCOS as well.
Okay. So we touched on briefly diet and exercise, nutrition. What role does food, let's go with food for the moment. What role does food have on, in general, female, fertility?
Yeah, but
like we all know that, what we eat affects our mood and how we feel in ourselves, but how does it have an impact on fertility?
I suppose it's actually massive, and it's probably much greater than we would have thought before. We know that different nutrients and minerals will impact your egg quality, and I suppose an egg that's of greater quality is more likely to become a baby. We know that different minerals, so for example coenzyme Q10 is more likely to make you ovulate and to regulate ovulation. Then in terms, I suppose, of the developing baby, you want to support that developing pregnancy as much as possible. Sometimes when a woman has a miscarriage, it might be that something wasn't genetically okay or correct with the developing embryo, so you want to support that process as much as possible. And that's where we start talking, I suppose, about things like folic acid, iodine. A lot of people are now talking about choline in the development of the baby as well. So the impact of diet and minerals is probably massive.
So when we're talking about a person's, nutritional, their daily intake, I suppose, should we be getting all of that from what we're eating, or do we need to take a rake of supplements?
Probably a bit of both. So I think in the first instance, you should try and get as much from food as possible. There's some that we don't get enough of. So for example, folic acid is the first one.
Sure.
Any woman of childbearing age, so basically any woman who's getting a period, should be taking folic acid. In Ireland, we don't get enough sunlight. We need to be taking vitamin D. If you're trying to conceive, probably it's no harm to take it the whole time, but October to April is the general rule. If you're thinking about conceiving, if you're a vegan or you don't eat fish, I would start thinking about omega-3 supplements. There's no recommendation in Ireland at the moment to take choline, but I'm seeing it a lot in US recommendations, so that's something to consider as a supplement.
What is choline?
It's another mineral, and it's thought to support the baby's development of their nervous system. Yeah.
And is that something that would be found in any sorts of food?
I actually don't know what food supplements food it's found in.
But you could get it in a supplement.
You'd get it in a supplement, or a dietitian would certainly be able to advise. And then it depends as well if you eat fish. Iodine would be another one that you might need to supplement. I suppose it's if it's financially viable, a broad supplement like there's different ones on the market.
Like a multivitamin.
Exactly.
Which probably most people would be taking anyways.
Yeah. Or I know there's ones that are branded for pregnancy itself, but it's probably...
They're kind of like the exact same, I'm pretty sure.
Yeah, it's all
just all marketing.
Yeah. If you're thinking about having a baby, it's, eat well, and maybe it's no harm to add in a supplement, and just to make sure that vitamin D, there mightn't be, sometimes there's not enough in them. So just to make sure that there is. And
would water... Like, again, we all know that it's really important to stay hydrated, but would that be like if someone is dehydrated all the time? I know myself, I often forget to drink water. Yeah. And I could get to 4:00 in the day and I'm like, oh Jesus, I haven't drank a glass of water. I've had lots of coffee. Yeah. How important is that? Probably it's important to support just the processes that go on in the body. Yeah. It's probably not the most important thing, but no harm for every part of your life to be making sure you're drinking enough water. And then in terms of kind of staying active, how important is that? In terms of, again, we know, just for general well-being and mental health, but just in terms of fertility, how important is that? I suppose it is important because, one, we do know that I know as well, BMI can be something that women find quite frustrating for us to talk about, but we do know that women who have what we call a normal BMI are more likely to conceive. So if you're of a higher BMI, you mightn't be ovulating. If you have a lower BMI, you mightn't be ovulating. So if exercise helps you to maintain a healthy weight, then that's obviously going to help. I think it cannot be underestimated the benefit that exercise has on your mental health and whether or not that's going to play a role.
And I also think that to go into a pregnancy in your fittest state, if possible, is a good idea.
Just with a lot of energy and...
Yeah, to have like a good reserve, to be fit and active. I think that's really going to stand to a woman if then pregnancy is something that comes.
Yeah. Okay. So when someone comes, I don't know if you would see people who maybe are struggling to conceive, what would be your kind of first port of call when you're, giving advice to someone?
Yeah, so we see women, I suppose, before and then after, if that makes sense.
Yeah.
So we see women I only work publicly, so we see women in the public fertility clinics, and this is where women would be referred in if they're having trouble conceiving, whether that be primary or secondary infertility. So I wouldn't have any actually exposure to IVF itself.
Yeah.
It's only then after it or IUI or ICSI happens that we'd see the
pregnancies.
the lovely pregnancies. So women might come to us with trouble conceiving. You'd go through, so you need a really, really strong and detailed history. So other medical problems, her periods, what are they like, what is she eating, is she on any medication? We do look at her BMI, we talk to her about her partner, and then you would start to do the primary fertility investigations. So on a first visit, what you might do is you would take bloods at certain points of the menstrual cycle. So we want to check that the whole drive behind the menstrual cycle is working. So from the brain down, whether or not she's ovulating, whether or not her progesterone levels are adequate. We'd look at her thyroid. We'd do the bloods just to see does she have PCOS, and we might know about it. And we'd also talk, if she's in a heterosexual relationship, we'd talk about getting a semen sample, where we look to see how much sperm is in a sample, whether it's moving, whether it's good sperm, we'll say. There's nothing wrong with it. They'd be the things you'd do in the first instance.
And then I suppose you'd then come up with some sort of diagnosis, or there may be no diagnosis.
Yeah,
it may
and
just
sometimes
be...
that's the more frustrating one, where you say these are all normal. While that's reassuring, it's frustrating for women to be told, well, we're not actually sure yet. And then you'd start to move on to the next ones. So if we know that you're ovulating and we know that the drive behind your menstrual cycle is there, we now need to look at other things. So the next thing we look at is your tubes, so your fallopian tubes, whether or not they're open or patent. There's a few different tests we use for this. So women might have heard of a HSG or a Hycosi, or a lap and dye, which is a little bit more invasive. And this is where we would inject a dye and take an X-ray or an ultrasound and to see if the dye goes through the tubes.
You would see it light up.
Exactly. So it's really rudimentary, I suppose. You're just seeing, does the dye pass through the tubes?
Yeah.
To see if they're open. And if they're not open, then great, that might be the driver behind this. But if they're open, again, you found another thing that's normal.
Yeah.
And sometimes it does come to you come to the end of all these and you say,
we can't tell you.
It's unexplained.
Yeah.
I don't know why you're not conceiving, and that's
And do you see that a lot?
You do, yeah. And I think that's really, really difficult for couples. And that is then where you start to talk about fertility treatments, which, probably couples didn't think about before. And now there's the financial burden of that for them as well.
Well, it's just not something, I think, is, if you're in a heterosexual couple, you just assume that if you want kids, it will happen. And yeah, as you say, I'm sure it's incredibly frustrating to be told there is no problem that we can see, but it's still not happening. And to be sent away to keep trying, what does that look like? It becomes a chore, and it becomes a pain point, and it's not enjoyable anymore.
Yeah, it changes, I think, the journey for people, and becomes really upsetting and really frustrating.
Yeah. Okay, so I'm going to now move on to some questions that people have sent in. So the first one was, so obviously we know that the lining of the womb or the uterus is really important in protecting a lovely little fertilized embryo. So how can you thicken the lining above 5 millimeters? Is that correct? 5 millimeters? Yeah. This person is on Femtab, 6 milligrams, but it's still only going to 4.5.
Yeah, so usually if you have a low or a thin lining, we do talk about progesterone supplements, because progesterone is the thing that allows that lining to build. If it's not building with progesterone, I would kind of probably advise this person to go for individualized assessment.
Okay.
Yeah, that would be she seems to be on the first line treatment, so that's a difficult one.
So it would kind of be further investigation as to what's happening.
Why, yeah.
Okay.
Why that's not happening.
We've touched on this, does BMI affect IVF?
It does. I suppose, one, we know that BMI does affect conception rates, and there are some clinics in Ireland who unfortunately have a blanket rule of where they won't accept women or patients with a BMI above a certain cutoff.
Yeah, which obviously we don't do that. It's a individualized care. Yeah.
So it affects it in that way in the first instance, and then women have to look for alternatives like yourselves, and it does affect success as well.
Yeah. Okay. So I guess it's one of, there are lots of factors that affect it, but it is one factor.
Yeah, to consider. Yeah.
Okay. Again, we've touched on this, but what treatments might work for patients with endometriosis? I'm assuming this is in order to get pregnant.
Yeah, I suppose if you have severe endo, and we're talking kind of stage 3, stage 4, it's surgery would be your option for fertility. So you'd need to be referred to a gynecologist who specialises in it, probably looking at a keyhole surgery to remove the endo that's there and to try and create some mobility in the tissues.
Here's a question, actually. This wasn't sent in, but just I thought of it there. If someone needs surgery, would it be possible for them to just do IVF, not just do IVF, but to go through fertility treatment, do IVF to become pregnant, or would they have to have the surgery first before doing the IVF?
No, you're spot on. So if you could go ahead with IVF without the surgery. I suppose surgery, you would need to definitively diagnose if you're stage 3, stage 4. So you could say, look, I just want the surgery to look, I don't want you to do anything. If it's there, we'll go ahead with the IVF.
Okay.
Yeah.
So you could just kind of have an investigation.
Exactly.
If you're kind of thinking of doing fertility treatment anyways.
Yeah.
But just to know exactly what's going on.
Exactly.
Okay. Can secondary infertility happen after a miscarriage, after your first pregnancy?
It's probably not linked, which I think can be really difficult not to associate it. Unfortunately, they're both things that are probably way more common than we think. So miscarriage, anything to 1 in 4 and 1 in 5 women, and secondary infertility itself is probably more common than we think. The two shouldn't be linked.
So it's not necessarily if you have a miscarriage after you've had your first baby, it's not immediately going to be defined as secondary infertility.
Exactly. Yeah, I think this is just an unlucky cascade of.
Is there a criteria for how many miscarriages you would have to go through for it to be classed?
Yeah, unfortunately, and it is changing. It's 3 in a row at the moment. Before we would consider there to be a problem and to look into it, but that is changing. There's a lot of work in the perinatal centre down in Cork that are kind of trying to drive change with this and to individualise assessment.
Is there any funding at the moment for those who are classed as having secondary infertility, or is that still there's nothing?
There's nothing. Yeah. And I think you might know better. I saw a graph recently and it's ranking Ireland
second lowest
in the EU for what we provide for women.
Yeah.
And I don't know, is there anything else we're second lowest in? Do you know?
I know it's completely crazy that there's no public assistance. Completely crazy and unnecessary, and just another way that we're failing, Okay, in your experience, do the PCOS cycles improve after you've had a pregnancy and after your first baby?
Not in my experience.
They kind of just go back to the way they were.
Yeah, no, I haven't experienced that a baby would improve symptoms.
Yeah, because I believe for many people with endo, while they're pregnant, the symptoms improve.
Yeah.
Yeah?
Yeah. So you've lost the hormonal drive, if that makes sense.
Yeah.
So the symptoms...
It's a whole different kind of hormonal drive then.
You've lost I was doing a little circle with my hand. You've lost the menstrual cycle drive where the hormones go up and down. So you abate the symptoms. Yeah. But unfortunately, once little baby is born, those symptoms
It goes
come
back to what it was previously.
So it's not cured, it's just
on hold.
On hold, yeah.
We really have to put up with a lot, don't we?
A lot, yeah.
Is an IVF pregnancy any riskier than any other pregnancy, and are there precautions that I should be taking?
Not precautions. I don't think I'd advise any precautions. They are treated as higher risk pregnancies. So I suppose we do put them into the higher risk pregnancy class, and there is also a lot of discussion when women come up to their due date about induction because of this. The evidence on it is quite weak, unfortunately, which can be really frustrating. But it will be classified as a higher risk pregnancy.
Yeah, no, I know. I was classified on two
With your
counts because of IVF and the diabetes.
Yeah.
So there was no way I was not going to be induced.
Yeah.
But I wonder, is some of that because a lot of people who are accessing fertility treatment are doing so because of other conditions that maybe would in turn, put them into a high risk category.
Exactly. And that's a little bit of the thought process, that actually is the higher risk status of an IVF pregnancy because of the underlying conditions.
Yeah.
And I think when we see more and more same-sex couples undergoing IVF, will we see different risk profiles in those couples, because a lot of if it's a same-sex couple, there may be no underlying condition. So I think as we see more of that, it'll be interesting to compare the two groups to see, actually, is it not the IVF that's high risk, is it the underlying conditions that preceded the IVF?
Yeah, I suppose the more data we have, the more we can kind of develop these. Yeah, because I know for a lot of my friends who've gone through IVF and they're classed as high risk, and there's literally nothing, there's no conditions, there's nothing, they're literally absolutely shouldn't be classed as high risk. But yeah, it's an interesting
so I think
one.
that will be an interesting one to look at, and it'll be, you will have two nice groups there to compare.
Yeah.
So that was good.
Okay, last question. Is there a correlation between pre-pregnancy weight and gestational diabetes? So you would see this in your, is it Tuesday clinics?
Yes,
yes,
and there is. So I'm always really careful with this, because for some reason when women get gestational diabetes, there's a lot of blame and guilt with it.
It's awful,
and you don't see it with anything else. So when a woman gets preeclampsia or obstetric cholestasis, there's none of that. But with gestational diabetes, there's so much. Women always say, I failed the test, or I obviously was eating too much sugar and things like that. So gestational diabetes is not your fault, and often there's nothing you can do. It's your response to the pregnancy hormones. But there is a higher risk of it if your BMI or your pre-pregnancy weight is higher. But that doesn't mean it's your fault, if that makes sense.
Yeah. And yeah, so actually, just to follow on from that, the test for gestational diabetes, is it still the drinking the gross
drink? Yeah.
That's the only good thing about having pre-existing diabetes, is not having to do that, because it's awful.
Yeah, I'd love to actually try it so I can.
You should try it, although it's literally pure sugar, isn't it?
Yeah.
So you wouldn't feel very good after.
I think, because I always say, I know it's awful, but I've actually never had it.
I think you should try it.
Yeah.
It seems, I don't know, it just seems bizarre to me to be giving sugar as a test, but I know you have to see how your body responds to it. But yeah, it's always seemed like a bizarre test to me.
Counterintuitive to give you something that we're telling you to avoid.
Yeah, no, and I know for just being in those clinics I was in every week, every second week throughout both pregnancies. So, and I'd see so many women with gestational diabetes, and just there's so much shame around it.
So much. And I think I put something on my Instagram recently, and there was, the response was, I found it really upsetting. It was people had been diagnosed with gestational diabetes, and it was the responses they got from medical professionals and from, we'll say, friends and family, and it was things like, oh, were you not eating a healthy diet? Oh, but you're so skinny. Oh, it was obviously, I saw you having that ice cream last week. There's so much shame, and you do not see it with any other condition in pregnancy.
Even like diabetes in general, you get people like, is that the good or the bad kind?
Yes.
Are you allowed to have sugar? Can you have no sugar? And it's a lot more complex and nuanced than that. And yes, I for sure know that there are a lot of medical professionals. Hopefully that's dying out. I'm delighted to know that you're in that clinic now. But I know that there in the past have been a lot of medical professionals who have not been so compassionate towards pregnant people. And just a lot of blame and shame and just making people feel bad, and there's no need, because it doesn't achieve anything. It's not going to improve the outcome for the patient. It's not going to make them feel any better. If anything, it's going to make things worse.
And less likely to trust you and to engage with you, and you totally break down the relationship.
And then they're just going to be lying to you. I know for a fact. The first time around, I didn't have Professor Daly. I had someone else who shall remain nameless. But I used to, fill in the little book. Now, on the second pregnancy, I had my insulin pump, so I would get all my readings from that, so I could just print it out. But the first time around, I didn't have that, so I'd be writing in the little book, your pre-breakfast, after breakfast, your blood sugar. And I used to just fill that in right before I went in. It's complete lies. Because I didn't have a relationship with my consultant. I knew that they would shout at me or berate me or make me feel bad, and I didn't need that, so I lied. So if your consultant isn't compassionate and understanding, you know what I mean?
Like, no good comes from that.
There's just no point in anyone even bothering to attend the clinic at that point.
Exactly.
Okay, I could talk about that all day, but anyways, I think that's us for today. Thank you so much for coming in. Pleasure to meet you in person. Pleasure to chat all things fertility, and thank you so much, and keep doing your amazing work. Who knows, I might see you at some point. Third time round.
Perfect. Thank you so much for having me on. It was a pleasure.
Thank you. We hope you've enjoyed this episode of Fertility Talks, the Therapy Fertility podcast. If you have, please rate, review, and subscribe. For more information on the services we offer, you can visit www.therapyfertility.com.